Good afternoon, ladies and gentlemen. My name, for those whom I haven't met, is James Ross, and I chair the Board of Trustees of the Liverpool School of Tropical Medicine. And it's my very pleasant task this afternoon to welcome you all to the 16th Leverhulme lecture. These are a prestigious series of lectures started in 1997. So there must have been a gap for a year or so at some stages, with the support of the late Viscount Leverhulme and indeed the Leverhulme Charitable Trust. And the series was established to attract lecturers of international distinction in their particular fields. So today we're absolutely delighted to welcome a former alumnus of LSTM, or in fact an existing alumnus of LSTM, Dr. Anarfi Asamoa-Baah, who is Deputy Director General of the World Health Organization. And that's probably the last time I'll give him his full name, because I understand your friends call you BA. No, AB. So if you will permit me, that may make my introduction slightly shorter. AB was appointed as Deputy Director General in January 2007. He trained originally as a doctor in the Ghana Medical School and was awarded a Master's in Community Health from the Liverpool School of Tropical Medicine. So it was downhill all the way after that. But he did actually do some postgraduate training in health planning at Keele University and health economics and health policy at the University of Wisconsin in the US. He started his career, in fact, as a medical administrator of a 180-bed district hospital in Ghana, and through progressive steps eventually arrived at being Director General of Health Services in that country. After spending something like 10 years as inter alia a consultant to the WHO, he actually joined the World Health Organization in 1998 as Senior Policy Advisor to Dr. Brunhild, the Director General. And over the succeeding 10 years before his present appointment, was firstly Executive Director for External Relations and Governing Bodies, then Executive Director for Health Technology and Pharmaceuticals, followed by being Assistant Director General of Communicable Diseases, and then Assistant Director General for HIV/AIDS, tuberculosis and malaria programs. So that's a very impressive track record looking backwards at the past and of his achievements. Now, AB is going to look forward in his Leverhulme lecture to talk to us about the subject of public health challenges in the post-2015 era. Over to you.
Thank you very much. It is said one of the advantages of having good friends is that you get very good introduction. And if you are lucky, your name can even be changed. So I'm now BA. Thank you, James. My dear sister Janet, my special brother David, distinguished colleagues and friends. Where I come from, we say all protocol observed. Really what it means is that there are so many important people that please forgive me if I don't single you out or I don't mention your name. It's really a great honor to return to a school where I was privileged to receive what is arguably for me the best education in public health in the world. When I had the opportunity, or I was offered the opportunity to do a postgraduate program in public health in the UK, I had two choices. either to go to the London School of Tropical Medicine and Hygiene, and bless them, they still talk about hygiene, or come to the Liverpool School. And it was not an easy decision to take because most of the people I knew, most of my mentors had gone to the London School. And when I talked to them, what they told me was that really there's very little difference between the courses offered by London School and Liverpool School. But there were two factors that made me choose Liverpool. One, everybody agreed that the people in Liverpool are nicer than the people in London. The second was I'm a football fanatic. And in those days, Liverpool was the place to go. Obviously, that's a long time ago. But at least this gives you an idea about how I take the important decisions in my life. They are very scientific and evidence-based. The time I spent in Liverpool was very useful, and let me explain why. My life passion had been to be a public health physician. But in those days, in my country, public health was not as sexy as clinical medicine. In fact, the people who went to public health were seen as the people who had fallen off the ladder, because most people who did public health at that time were people who have tried to specialize in clinical care and have failed their third exam, so you branch into public health. So public health was not sexy. So the way to be credible was first to do clinical medicine. So I wanted to be a pediatrician. So after qualification, I entered the postgraduate program in pediatrics at the premier teaching hospital. In my second year, I was approached by an uncle of mine, and in Ghana, anybody who's older than you is an uncle. An uncle of mine, but this was a proper uncle, who at that time was a Catholic bishop. And the Catholic Church has hospitals in many parts of rural Ghana, but most Ghanaian doctors don't want to work in those hospitals. And so many of these hospitals were managed by expatriates. And what he told me was that really if I offered to go and work in one of these hospitals, the Catholic Church will sponsor me to go and do pediatrics in the US. So I moved to one of these rural hospitals, and it was really an eye-opener. I mean, just a few years after qualifying to be a doctor, you are exposed to everything. You have to do all type of surgery. So in a matter of months, I could do amputation, grafting, and even could repair fistula. But what really changed my life was a year after I've been there, many of the expatriates, all the expatriates decided to leave. So I moved from just being a clinician to also managing the hospital. And this was a big hospital of about 150 beds. So I moved into not only clinical work, but also managing money, managing people, managing supplies, managing vehicles. And the difficult part was really managing. This hospital was run by Catholic nuns. So the difficult part was managing Catholic nuns. I don't know whether you've had the fortune or misfortune of managing Catholic nuns. And to make matters worse, these were Catholic nuns from Nigeria. Can you imagine? This hospital also had what we call an outreach program. And it used to be called primary healthcare program, where we went to the communities and offered services. And really that is what changed my life, because it dawned on me that really what we're seeing in the hospital is a far cry from what really happens in the community. Even in this rural hospital, we're not seeing many cases of the so-called neglected tropical diseases. But when you go to the communities, these were the problems that many people were facing. But it also taught me that health is not just about diseases. It's about people. It's about the environment. It's about where they live. It's about their socio-economic environment, their culture. And health is also about politics and policies. And the neglected tropical diseases provide an excellent and dramatic example of the linkages between poverty and disease. And this is where my interest in neglected tropical diseases grew. So I really wanted to go to a school where all these are brought together, and that is why I found my experience in Liverpool very stimulating. Because I had an opportunity not just to learn about diseases, but to learn about all aspects of health. But since I left the school, I've been following the developments in the school, and I know, and from what we heard today, the school is a much better place than what it was when I was a student. So I want on your behalf to also thank the people who came after I've left and made the school a better place. Janet, David, and the rest of you. Thank you very much. But more importantly, a lot of the progress that we've made in NTD has also been partly because of what the school has done. So on behalf of what we call the bottom billion, the voiceless, the faceless, the powerless, I thank the school for conducting the type of work that has made this visible reality. I realize that I came here not to praise the school, but to reflect and to share some reflection on the public health challenges of in the post-2015 development era. I recognize also that we've had a long day, and these chairs are not meant to be comfortable. So, to quote King Henry VIII, I will not keep you long. But more importantly, we will have an opportunity to interact and have questions and answer session. Why the post-2015 era? As you know, at the beginning of the millennium, there was a feeling that the world needs to do something big for development. And the consensus at that time was that the biggest obstacle to development is poverty. And that is how the Millennium Development Goals were formulated, to reduce extreme poverty and to make sure that most people get out of poverty. Luckily for health, it was recognized that health is an important component of this. And out of the 8 goals, 3 specifically were about health. And we say really all the 8 goals are health goals. And the focus at that time was to make health simple so that head of states and especially US congressmen can understand. So health needed to be put in a kindergarten language. And for most people at that time, health was about 5 things. It's about HIV, TB, malaria, child health, and maternal health. So that was how the Millennium Development Goals in the concept in the area of health was conceived. As you can imagine, this created another set of problems, especially with the NTD community. And it wasn't a community at that time, because the NTD community at that time was made up of about 15 to 20 different tribes. And these tribes were not talking to each other, but they had a common feeling that they've been neglected by this movement. And some of us said, rather than attacking HIV, TB, malaria movement, because the world is capable, the world need not choose between HIV and neglected tropical diseases. Can we come together as a group and even change the narrative? And that is how the first Berlin meeting was organized in 2003, where we brought together a number of people and organizations working in the area of NTD. But part of the language was that, or the narrative was that we need a new name. And there were people who were wedded to the idea that we were a neglected group. So they were hooked on keeping the word neglected. And we worked together to say, can we change even the narrative of neglected? We are not neglected. It is the populations that are neglected. And change the narrative, since the main purpose of the MDGs is about poverty. Link this with poverty. And that is how the movement of neglected tropical diseases was formed, and the rest, as they say, is history. But the main point I want to make here is that the last 15 years has been good for global public health. Let me give you some figures. For many years, the number of children under 5 dying a year stuck around 10 million for many, many years. Last year, it dropped to a little over 6 million. And it's now falling faster than ever before. Each day today, 17,000 fewer children die than in 1990. So we've made a lot of progress in the area of child health. In HIV, the AIDS epidemic reached a tipping point last year. Last year, for the first time, the number of people receiving treatment exceeded the number of newly infected. This is a new balance sheet that is really good for the future. At the end of last year, nearly 13 million people in low and middle income countries were receiving antiretroviral therapy. This achievement ranks as the fastest scale up of a life-saving intervention in history. Malaria. Last year, WHO issued a report on the world malaria situation, and that was the most encouraging. Many countries in sub-Saharan Africa have recorded reductions of more than half, 50% in malaria morbidity and mortality. We owe much of this success to advances in vector control, where this school has been a leader. In tuberculosis, we're now targeting 30 countries for elimination. And many researchers have responded, including researchers in the school, to the call for improved diagnostic tests, a better vaccine, shorter and more effective treatment regimes. Now let me move to a little about neglected tropical diseases. We've heard some this morning, but it will not be fair if I don't talk about some of the progress we've made in neglected tropical diseases. So let me give you a few statistics. As we heard this morning, well over 70 countries, 70, are implementing or ready to kick off their master plans for the integrated and accelerated control of these diseases. Verification in lymphatic filariasis has been eliminated. Verification that this has been eliminated has begun in 6 countries. 10 years ago, nobody believed this was possible. Sustained effort by many countries have reduced, as we heard this afternoon, African sleeping sickness by 90%. Industry has donated enough medicine to blanket all endemic countries with preventive treatment for schisto. And as we heard this morning, more than 5 billion antiparasitic treatments have been delivered to the poorest people in the world. So we have a lot to celebrate, and that is my second message. My first message was to start the school. My second message is that we have a lot to celebrate. And a lot of these initiatives are paving the way for an exodus from poverty. But even though the MDGs were focusing more on infectious diseases, we've also seen a lot of successes on the non-communicable disease front. Tobacco smoking is no longer sexy. Many decades ago, in many homes, you will find ashtrays. Every car even had an ashtray fitted in the car. Now you don't find them anymore. People still smoke, but as they do in the airport, if you want to smoke, you go into a cage. There is now, people are more worried about exercises. People are getting more choosy about their food. These are all positive developments. What have we learned from all these positive developments? Many, many things. Let me share a few with you. First, we've learned that investment in health development brings results. So I would like here to pay tribute to all those who have contributed to this. But we also learned that setting targets, measuring progress matters. This is something we learned from business. Developing metrics. Because as they say, if you cannot measure, you cannot manage. And that is why all these countdowns are important. But we also learned that individuals matter. We need champions, we need advocates, we need mentors, we need sponsors, and we need cheerleaders. But we've also learned that institutions matter. Having institutions like the school, like the World Health Organization, there's only one World Health Organization. We learned that the private sector could be part of the solution. Sometimes they don't get the credit that they deserve. But of course, this is something we knew in Liverpool, that really business is part of the solution. For many years, public health has seen industry as a problem and not part of the solution. But more importantly, we've learned that working in partnerships are important. Sometimes coming together, coming together we maximize our assets. There are some things WHO can do, the school cannot do. But there are also some things the school can do that WHO cannot do. So working in partnership is very important. These successes are important as we transition into the post-2015 era. Because bringing well-known diseases under control frees hospital beds, staff and resources to respond to more complex challenges. But these successes also have political capital. When populations see empty malaria and measles wards, or young adults living productive lives, or hear that guinea worm has been eradicated, their confidence in government, their confidence in public services grow. So we need to see this not only in the context of reducing diseases, but also generating confidence in public health, but more importantly, confidence in government. My next main point is that in the future public health challenges are going to be more complex than what we've gone through the last 15 years. In many ways, the last 15 years we've been ripping low-hanging fruits. And let me illustrate this with three of my favorite examples by looking at events in the previous century. In 1945, I was only 10 years old then. Oh, no. Alexander Fleming and two other physicians were awarded the Nobel Prize in Medicine for their discovery and development of penicillin, the world's first antibiotic. In his acceptance speech, Fleming asked clinicians to administer penicillin with utmost care. because overuse and underuse will hasten the development of resistance. This was in 1945. The era of modern medicine was thus ushered in with a prediction that it could, through irresponsible use of fragile medicine, also abruptly end. Another favorite example is a photograph that I saw quite recently, and this photograph was taken in 1947 in New York. It showed long lines snaking along the city sidewalks and streets as thousands of people patiently waited to be vaccinated against smallpox. People lining the streets of New York to be vaccinated against smallpox. These days, when people line the streets of New York, they are waiting for iPhone 9, not... These were the days when people had full confidence in science, trusted advice of health officials as they did now. Now we don't believe in health officials. A third example, what I call the first frozen TV dinners entered the market, and it quickly changed the way millions of households spend their evenings. That convenient invention illustrated the ability of industry to capture emerging social trends, to cater for them with innovative products, but also to reinforce these trends through aggressive marketing, thus perpetuating the demand. With this, a generation of chubby couch potatoes shaped by sinking prices for TV sets and the appeal of convenience food was born. The discovery of miracle medicines, public faith in the science, the use of new technology to improve food supply were all good things that went bad. Fleming's warning fell on deaf ears. Now we are seeing widespread use of antimicrobial and the development of resistance. The public, as I mentioned earlier, some have lost faith in science. People no longer line up obediently to follow public health advice. People form their own opinions. The rise of social media means personal views get taken as fact and widely propagated. These are some of the challenges that we face. As some of you know, quite recently there was a measles outbreak that swept the United States. Measles outbreak in the United States. Misinformation and unfounded fears allow the disease that belongs in the history book to come back. Countering these fears have not worked, because one of the hardest challenges we face is changing human behavior. Advances in food technology have made food supply very secure, but they've also changed its nature. The industrialization of food production has paved the way for a corporate approach to food supply that concentrates exclusively on increasing the quantities and reducing the cost of food. And I'm not just referring to the US. The primary purpose of the food chain has always been to provide nutrients that sustain human life, has lost its way. Now we have highly processed food, rich in fat, sugar, salt, but low in essential nutrients. This morning we've heard a lot about NCDs, so I want to move you to another group of diseases that are also tropical. Because In our closely interdependent world today, everywhere, health is shaped by the same powerful forces. Population are aging, not only in this room. The middle class teenagers are the same everywhere. A middle class teenager in Kenya is no different from the middle class teenager in Liverpool. They dress the same, listen to the same music, eat the same fast food, have the same role models. And under these pressures, chronic non-communicable diseases like heart disease, stroke, cancers, diabetes, chronic respiratory diseases have overtaken infectious diseases as the leading cause of mortality worldwide. And in many so-called poor countries or tropical diseases, the biggest challenge is not infectious disease. It's going to be non-communicable diseases. This shift has profound implications. Medical research is one of the few areas where innovation, where technologies keep getting costly and more sophisticated to use. This is not the case with computers, flat-screen televisions, where products are progressively getting cheaper and more friendly to use. Most infectious diseases cause brief episodes of acute illness in which the patient survives or dies. But the cost of chronic care for diseases like cancer, diabetes, have become unsustainable for even the richest countries in the world. So now everybody agrees that prevention must be the cornerstone if we want to have an appropriate response for non-communicable diseases. NCDs, not NTDs, I'm talking about NCDs. But prevention is more complex than in the past because the determinants of health are so broad. Prevention has always depended on cooperation with non-health sectors. In the past, this involved working with sister-friendly sectors like education, nutrition, housing, water. But now this collaboration needs to tackle the root cause of NCD, but also needs to aim at changing human behavior, but also the behavior of powerful economic operators. Industries producing harmful products, I hope I don't get into trouble, like tobacco, alcohol, junk food, sugar-sweetened beverages are neither friendly or eager to cooperate, as doing so undermine rather than reinforces their business goals. They need to learn from the pharmaceutical industry. Unfortunately, this is not a level playing field at all, because market power readily translates into political power, and few governments prioritize health over big business. These industries resist any fiscal or regulatory measures aimed at changing behavior. Their tactics are versatile and well-founded. For example, there are many countries now planning what we call plain packaging for tobacco products, but they are being intimidated by threats of costly and protracted litigation from tobacco industry. So the future challenges are going to be very different from the challenges that we faced. Pursuit of the MDG goals did not face the type of hostile resistance that we're going to face with non-communicable diseases. No one said efforts to reduce child mortality was interference with personal freedom. by the nanny state. Mosquitoes don't have front groups. Mosquitoes do not have lobbies. But the vectors of tomorrow, the disease vectors of tomorrow, have lobbies. They are well founded. And yet another complexity, NCD challenges the very way that socio-economic progress is defined. In the past, many infectious diseases vanished as society progressed, as education, living conditions, and income improved, and environmental threats were removed. The rise of NCDs have turned this situation around. Socio-economic progress is actually creating the conditions that favor the rise of NCDs. Economic growth, modernization, urbanization have opened the entry point for the spread of unhealthy lifestyles. To give you one story, 2 years ago, Chinese researchers published the results of a very large national survey designed to measure the prevalence of diabetes in China. And the authors estimate that in China today, there are about 114 million adults living with diabetes, representing a prevalence in the adult Chinese population of nearly 12%. Looking for an explanation, the author suggested that modernization and rising income were preparing lifestyle changes, including a shift from traditional healthy diets to westernized diet. But what was interesting is that media coverage of these alarming findings prompted a Chinese newspaper to run a cartoon showing a patient with his doctor, asking the question, "Doctor, is there a cure for diabetes?" And the doctor says, "Yes, it's poverty." Distinguished ladies and gentlemen, the rise of NCD is not the only challenge that lies ahead. The Ebola outbreak in West Africa has revealed that the world is ill prepared to respond to any epidemic that is both severe and sustained. The world went to battle with this disease with no war chest, no army of reinforcement, and control tools dating back to Middle Ages. But it brought home that infectious diseases are not dead. But the infectious diseases of the future will be very different. Because the infectious disease of the future will not kill many, but they will terrorize many. Because they will travel. A lot of the diseases we talked about did not terrorize many because they don't travel. Infectious diseases of the future will travel. Infectious of disease of the future will be more democratic because the world is on the move. We are all traveling. Traveling is a lot easier, EasyJet. And these diseases need no visa to travel. They don't respect political or geographical boundaries. This morning, David mentioned that if you look at the noise and the panic that was associated, is still associated with Ebola, compared to the number of people who have died from it, is because this is an example of the infectious disease of the future. Not many people died, but airlines stopped. The economy almost collapsed. Governments always fall. And this is not, Ebola is the last one, but it's the same with SARS, pandemic flu, Mexico virus. So we've get into an era of new infectious diseases that is not measured by how many people die. But because we live in a world that is getting smaller and smaller, with 24-hour breaking news, whether you like it or not, it will come to your sitting room. We need to look at infectious diseases in the future in a different way. The other challenge is that the poverty map is changing. So it's no longer poor countries and rich countries. 70% of the world poor now live in middle income countries. They don't live in poor countries. The rise in gross national income does not automatically mean that the government is now able or willing to invest in health. Economic growth, which has long been the principal measure of progress in the eyes of the world, is changing. If the economy is doing well, where is the incentive and pressure for governments to have equitable health care? One of the movements the last 15 years was the establishment of global initiatives and special funds for immunization, for HIV, for TB, malaria. As these global initiatives withdraw financial support as economies grow, the likely result will be there will be more rich countries full of poor people. We're going to get to the stage where there are a lot of poor people in rich countries. So looking at countries is no longer the way forward. It's looking at communities. In every country, there are communities that are neglected. And time has come to begin to focus on those communities. For a long time, the way we've measured progress is to look at averages. The average infant mortality rate. It doesn't mean much, but that is what we all like. The average height of an American. What does that mean? It doesn't mean much, but we're all interested to know about averages. And one of the lessons we've learned the last 15 years is to move from averages. Someone said on the average, if you put your leg in ice and you put your head in fire, on the average, you are okay. Our climate is changing. Beautiful weather today. We've seen records of extreme weather events, and the world is gradually beginning to appreciate that human beings and not the polar bear really is the most important species endangered by climate change, because it affects the way the water we drink, the food we eat, and the air we breathe. We know from our work that many vector-borne diseases are highly sensitive to climate variables. Dengue is one. In recent years, the principal insect vector that transmits disease has silently spread and is now present in more than 150 countries. Dengue is in more than 150 countries. But the other complication is, like climate change and many other areas, health has no say when policies are being set for the international system that govern finance, business, trade, and energy use, and yet health bears the brunt of this, because usually when there are discussions in these sectors, we are not there. We are good at talking among ourselves. talking to the disciples, but we are not present when trade agreements are being discussed. And trade agreements sometimes have more effect on health. As someone said, at the negotiating table, if you are not at the table, you are on the menu. In the future, health professionals must not only be interested in so-called health issues. We need to be interested in trade issues, in finance issues. The fact that the World Bank and IMF once said user charges don't employ health workers have had adverse effect on health services. But health was not there because we were busy having scientific conferences among ourselves. But the good thing is that public health is very optimistic, discipline. We're used to fighting in the trenches time and again with optimism, evidence and ethics on our side. We've confronted head-on and sometimes circumvented negative forces. For AIDS, HIV/AIDS, for example, the combination of civil society pressure on pharmaceutical industries, and I don't mean GSK, a solid regulatory system for approving generic products, assurance by national governments and donors of a significant and reliable market has reduced the price by more than 100-fold. A program for pre-qualified medical products based on standards, rigorous standards of quality assurance has leveled the playing field for pharmaceutical manufacturers from low and middle income countries, allowing them to compete, sometimes even footing with long-established companies. Supplies of quality assured products, forecasting, and competition has brought down prices significantly. And this has changed the dynamics of the market for public health vaccines and other products. These are all positive developments we need to take care of. But we know for most poor people, the price for essential medical interventions, no matter how low, is affordable. And it is this reality that has guided and shaped the policy recommendation that for mass distribution, that free bednets should be free for malaria and the mass donation of preventive medicine for neglected tropical diseases. Ladies and gentlemen, I promise I will be brief. But I also know a lot of the time when people say I'm going to be brief, what they actually mean is that I'm not going to be brief. So I'm not going to be brief. Let me conclude with two main lessons that need to guide the post-2015 health agenda. These are lessons that's firmly rooted in recent experience. First, of all the health-related MDGs I talked about, the one for reducing maternal mortality has been the most problematic. Why? No single intervention like bed nets, vaccines, or cocktail of medicine works to prevent these deaths. It's been problematic because reducing maternal mortality depends on a well-functioning health system. It doesn't depend on mass treatment. It depends on a well-functioning health system with access to skilled birth attendants and emergency obstetric services. The Ebola outbreak laid bare the tragic consequences of weak health systems. severe shortage of health workers. Health workers badly paid, some cases not being paid. Limited surveillance, limited diagnostic capacity, broken down hospitals with no electricity, running water, no isolation wards, lack of essential medicine. It's brought home to me as I started my short talk. I moved from clinical medicine to public health. In the evening of my life, I've realized that really clinical medicine and public health needs to go together. The dichotomy between public health and clinical care is not helpful. We need to bring clinical care and public health together. And that requires a strong health system, which is something we have not really invested in, because we are always looking for the magic bullet. The challenges of the future will not respond to magic bullets. And that is why we need to begin to think about strengthening health system. And that is why I was really glad, as part of our presentations today, to hear about strengthening health system. This was something that was difficult to explain to people many, many years ago. What is health system? They can understand vaccine, they can understand medicine, but they can't understand health system. Julie is here, so I won't say that. Mr. Bill Gates, when we met some years ago, said, "You people, you just talk. I don't understand health system. Can you explain what is a health system to me? I understand technology, but I don't understand health system." And our simple explanation is that yes, vaccines are wonderful, but vaccines cannot fly into children's arms. The process by which vaccines move from the factory to children's arm is health system. So say, I understand now. You are talking about delivery system. And that is why these days the foundation, bless their heart, talks about delivery system. We need to begin to talk about a health system. And that leads me to my final point, and this is my first final point. Julie made a very good point. All lives have equal value. But is it really true? Is it really true that we believe all lives have equal value? Everybody in the UK, for example, believes the NHS is wonderful. But when you say, can we export the NHS to the rest of the world, the answer you get, yeah, but it's too expensive. All lives have equal value. Our world is a rich world. One of the concepts I like very well is the concept of a failed state. And there are many in where I come from. Failed states are not poor states. In fact, they are rich states. But they are failed states because a minority have hijacked the resources of the state and do not make it available to the majority of society. And everybody can understand the idea of a failed state. But look at that. Look at it in a different way. We are a failed globe. Our world is a rich world. There are 6 people who have more money than 600 million people. There are people who are richer than countries. Failed globe. But why have we not made this argument? Because we have not learned what Liverpool learned many years ago. we need to change the narrative where development is a charity into where development is enlightened self-interest. The school was established by a businessman. He knew for enlightened self-interest, he needed to find cure for these tropical diseases. Otherwise, he's out of business. But we've not been able to make that argument. Unfortunately or fortunately, infectious disease of the future are beginning to make that argument. To quote President Bush, I never thought I would quote President Bush. If you want to protect the American people, you have to fight the terrorists at home. If we want to protect ourselves from the future infectious diseases, we must fight the infectious diseases at source. Unless we do that, we are not protected, because our world is becoming a small village. And when we move our argument from that of charity into self-interest, we move from millions into billions. A lot of the wonderful work that we've talked about is founded by, in the UK, DFID, because it's seen as charity. If it's seen as self-interest, it will be funded not just by DFID. It will be funded by defense, by big money. Our world is a rich world. And that is why we are really encouraged in WHO about the encouraging trends we're seeing in the growing number of countries that have made universal health coverage the goal for health system reforms. We learn from Ebola. Unless every country is prepared, no country is prepared. Unless every country is prepared, no country is prepared. And that is why one of the biggest movements in the next generation of MDG goals, called the SDG goals, is the idea of universal health coverage. Because we believe that it is the ultimate expression of fairness. It upholds the highest ethical principle of public health, that no one should be denied access to life-saving or health-promoting interventions for unfair reasons, including those of economic or social causes. Because we know that equitable health contributes to social cohesion. It contributes to stability and harmony in human relations. A world facing so many disruptive challenges on so many fronts needs these assets. We have an opportunity to change global health. History will not be very kind on us if we fail. So we must not, and we dare not fail. I thank you.
Stay there. AB, you've been, as you promised, so brief that, you know, we've practically run out of time for questions. But as I said to you before we started, questions often are the best part of a presentation of this sort. Though it's going to be hard to surpass what you've just been talking about. So let's steal some time, some of your drinking time, and have some questions. There are microphones somewhere around. So who's got a first question? Up at the back there. Yeah, okay, there, right there. Lovely.
Thank you. Thank you for the most interesting lecture on the public health challenges in the post-2015 era. I believe that it has covered most of the things that I would have imagined, but I was wondering whether we could talk about the role of global insecurity and the relationship with health outcomes, especially when it comes to insecurity, especially in the poor countries. The countries that are experiencing a lot of wars and conflicts have also poor health outcomes. So I was wondering whether the WHO should engage, have some democratic peace and conflict resolution engagement at the country level to address this problem in relation to the public health challenges in post-2015 era. Thank you.
Would you like to address that one, and then we'll take
It's a very
another
good
two?
point. I mean, health emergencies are really on the increase. And as you rightly said, it has very severe health consequences, especially for mothers and for children. And this is an area that the WHO, for example, is beginning to increase its work in that area. So thank you for raising that point. I didn't mention that explicitly, but you are right. The last few years, we've seen many countries that had relatively strong health systems, but because of conflict, Libya, Syria, these were not countries that normally one would talk about as poor countries. But there are so many people displaced, both inside and outside, and the world is not paying enough attention to the health consequences of this emergency. So thank you for bringing that up.
Okay, there's one up at the back here. Yeah.
Thank you very much, Dr. Asamoa-Baah, for the presentation. My question is really, in responding to these public health challenges for the post-2015 era, I believe there have to be post-2015 public health practitioners that should be prepared for this work. What do you think a school like the Liverpool School of Tropical Medicine should be having as part of the curriculum to prepare, new practitioners to respond to this? Thank you.
Very good point. That was one of the points I was gently making, that we need to prepare the future public health practitioners for the future, not for the past. And sometimes we do prepare for the last war instead of preparing for the next war. The next public health practitioners who have to be rounded practitioners that focuses on some of the issues that we talked about. And the school is doing very well, but really not, for example, the focus on NCDs is not really a priority for the school at the moment. But for most poor communities, they have comorbidities. They don't have the luxury of choosing between infectious disease and NCDs. It's not uncommon in the same family, for example, to find a child who's malnourished, a mother who's overweight, the father with hypertension. And we go in and say we are only interested in giving you this tablet, and another group will come and look after you. We need to move into a people-centered approach. So it is not about integrating diseases anymore. It's about people-centered. And that may require looking at it from the people's perspective. But at the moment, we integrate diseases, LF versus this. But the person with LF may also have hypertension, have diabetes. So you get my point. Yeah. Janet is listening very well.
She may have a chance to respond in a minute. Yes, in the middle there. Yeah.
very much for that. I was just wondering, you know how you're talking a bit about working in partnership with private entities and corporations and things like that. I was just thinking of it in terms of the NCDs and obesity and fast food and all that kind of thing. And you're talking about tobacco and things like that, and it doesn't seem like the fight against tobacco was much of a holding hands in partnership kind of collaboration. And I was just wondering how realistic you thought it was that somehow we can work with private corporations to help with these kind of issues, and who thinks the approach should be really for governments and things.
A very good question. The fight against tobacco has been also a fight against industry, because our point has been there is no health benefit to tobacco. But that is not the case with food. So our approach to food industry needs to be different. It cannot be get rid of tobacco industry. So we need innovative approaches to dealing with industry. Industry is also not homogeneous, and sometimes we treat industry as if it's a homogeneous group. There are people in industry who have the same good heart we have in public health, but our approach to industry for a long time has been they are the evil. And it's even worse in an organization like WHO, which is a member states organization, which tends to look at governments are wonderful, NGOs are okay, but industry is wrong. And it's not been easy to change that type of perception and approach. And that is why the work with NTD, for example, is changing how organizations like WHO deal with industry. 15 years ago, we had the same, to some extent, antagonistic approach to even the pharmaceutical industry. And that has changed. So I also hope our approach to the food industry, our approach to the alcohol industry will change over time and not be passing along the way we worked with, or we did not work with the tobacco industry, because our position has been there's no health benefit to tobacco. It's the only industry where the purpose of the product is to kill people.
One over here, yes.
Thank you for your presentation. It was wonderful. It was a very positive note that the indicators we're most interested in for MDGs are indeed increasing, but to refer to your wonderful joke, those are averages, and averages mask the variation within the countries. Hence, I would expect that even in very successful countries, there are going to be portions, like in Ghana, in the northern regions, for example, similar in Uganda, northern regions. These problematic areas sometimes can escape attention because of the average of the nation as a whole. So as we now look to the post-2015 era, and fashions can evolve within our health sector, and sway attention away from these unfinished tasks. It's so important in these current agenda for those tasks to be finished, which really require the empowerment of local health systems, not just national ones, so that they're able to be more empowered to govern themselves to finish the tasks. If that does not happen, then when we come to non-communicable diseases, the same problems will ensue. So it'd be wonderful to see a more explicit policy from WHO that focuses on governance, local empowerment, and the enhancement of health systems at that level in a very explicit way, so as to recognize that the Ministry of Health is indeed a system that, like industry, really requires those factories that are located at the periphery to perform at their highest standards.
Very, very good point. Really, that is the, if you like, the challenge of NTDs. As we get the type of success that we're talking about, the poorest, the disease remains with the poorest of the poor. And there is the risk that the world will say you've made so much progress. And in public health, you get money if you are doing badly. In economics, if you're doing very well, you get more money. In public health, if you're doing more well, you get less money. If you are doing badly, you get more money. So there is a risk that now that even the diseases have been connected to parts of the world where it is even more unreachable, communities that are unreachable, we're going to go away and say we've made it. So the idea of local health system, not the national health system, is really a very important point, because that is where we will make the difference.
Okay, is there one last question down here? Well, yes. She who shouts loudest, yes, gets the last question.
I have some advocates in my corner here. Hi, I'm Robin. Thanks for that really engaging presentation. It was really, really thought-provoking. You mentioned talking about changing the narrative around how we're pitching aid from charity to be more a self-interest from a state perspective, because it's a failed globe rather than a failed state. I just think that there's some risk there with it being quite a top-down approach then, because money equals power. So I'm wondering, what are we going to do to make sure that the context is still embedded in processes and that it's not such a huge power struggle between those with money and those that are receiving money from a self-interest perspective?
Very good point. I wasn't only looking at it in the context of rich countries versus poor countries. Even in countries, most of these NCDs, they are not the priorities of countries. And the challenge we face now, we've made a lot of noise, we've raised a lot of money, we have a lot of donations. We still have the challenge of convincing countries, because they look at their statistics and these things don't appear, because these poor people are not part of the statistics. They are not counted. All right. So I wasn't just talking about shaming rich countries, but within the countries. Because part of the statistics is global, it's national. It doesn't go into those areas. So one last question, if it's a rapid one.
Thanks very much for your talk, AB. I was particularly interested in your history at the beginning, which I didn't know so much about, and the different jobs you did. And from your talk about the public health challenges, what it seems is what we really need is a very flexible workforce to be able to adapt to the different requirements. And you've sent a message to our director about training and skills and so on, but I wonder about your experience as a manager of Nigerian nuns and the Director General of a national health service, and your experience in WHO, whether you have thoughts about what kind of management is needed to ensure that the whole workforce in a health service remains flexible, can be flexible, remains flexible as the different needs change. Thank you.
It's a very simple question from an expert. So I learned many years ago in medical school that if your professor asks you a simple question, don't assume it's an innocent question. You made a number of points. One is about how do we train the health workers of the future? And the second point is that how are we managing workforce? And really that is an area that is not well managed. If you look at the budget, the national budgets, more than half is about workforce. And yet the approach when we want to build a hospital, the type of appraisal, the type of system that go into that is nothing compared to how we approach health workforce. I learned management the hard way. People are really not groomed to be managers. You at the evening of your life, when you've not been trained as a manager, you are turned into a manager. So, 2 losses. One, you lose a very good scientist, and then you have a hopeless manager. Of course, the exception is Janet. So, I'm not sure about David, but yeah, So, we need to think through that aspect very well, where people are promoted to their level of incompetence, and management is seen as common sense. And people are really not groomed to be managers, and yet you are given the responsibility of managing. So that is an area that really we've not paid a lot of attention to. But the bigger thing is your first point: how do we prepare the health workforce for the future? And it cannot be the way we've done it, with specialization, where people specialize. And one thing I've learned, the more people specialize, the narrower they are. They specialize and become a cardiologist. They don't know anything apart from cardiology. Anytime you want to talk to them about fashion, about sports, they want to talk about cardiology because they are specialized. And the more specialized they are, the narrower they are. You can't have any conversation with them. And that is where, in the medical profession, that was the approach. You become a specialist. So, someone said, I know someone who specializes in the left eye. So if you have a problem with your right eye, no, I specialize in the left eye.
So I think we're going to have to draw a close at this point, and it's my very great pleasure on your behalf to thank AB for a fascinating talk. Behind that infectious Ghanaian sense of humour and the image of AB as a young man herding Catholic nuns will stay with all of us. There were some really very profound and very serious messages for us that I'm sure we'll go on reflecting on and discussing for quite some time. So if we could show our appreciation in the normal way. And now I'd ask Professor Janet Hemingway to present the Leverhulme Lecture Medal.
AB, it's a great pleasure for me to present you with this. Thank you for all your kind words as well. I'm assuming when you finally retire from WHO, you'll come back and lecture to us and the students as well. I think that would be entirely appropriate. But we've all had a great time this evening. I think you've given us a huge amount of food for thought, and I do hope we'll see you in Liverpool before much longer. I think we need to look that direction, and then they will take a picture of us as well. Thank you very much. And for those of you who didn't get to answer the questions, I'm sure AB will allow you to corner in briefly at least and ask 1 or 2 more questions as we have a drink downstairs in the area where we've had teas and coffees earlier for those people who are there. Thank you very much.
Very good. Terrific, brilliant, great.